Core to the cloud. Excellent. How are you this day?
Okay. Yeah, excited.
I'm okay, Mike. All right. Let's see. Let's see if I can. Yeah, direct to Facebook is not working as easily as if I say stream to custom streaming service.
That's all in Zoom.
That's within Zoom. And then I go to my Facebook page and I say live video. Go live, and then I can choose to sort of essentially there's an option to create to plug in some streaming details. Okay, so stream key. I copy that. I can share more with you later.
Yeah. We're going for an hour or less.
I'm happy to aim for an hour and just see where we go. I mean, I think that
Okay.
I'll be very curious to see. I'd love to just name one or two specific examples, and then also like about how one makes decision when trying to help somebody, re-regulate or reorganize their sense of self, their movement, etc. And if it feels like we have gone from the specific to the theoretical and back, or you know, I'm down to conclude.
Okay.
Let me try that.
Just reminding myself because I'm doing this with lots of different people and I'm kind of confusing them.
We had agreed on an hour. Okay, so now I'm just share my screen with you so you can see what I'm doing. Now there's this Zoom connection, and perhaps that has just gone ahead and gone live. If we are live, Mark, I want
I'm
to
on
say
your page and I don't see it.
I don't see it either. Oh, I see. Okay, no, here's the live producer. Here's a little inception moment here. Okay, so this is our preview screen, and then we need to like add some post details for this to happen. Uh, Ecology of interoception and related stuff.
Sounds good.
Um, it should allow me then to, good. I'm good with that. What else? What else is required? Okay, connect live edit, complete post details. I think I did those post details. This is the point where I always don't understand what more it wants from me.
Right. Yeah, I can see.
Select your audience. Done. Oh, description required.
Uh,
A friendly, collegial. discussion with the inimitable Dr. Mark Olson.
Oh, I've never seen that word spelled before.
All right. Now it says I've completed the post details. Now we have the option to go live. And so what I will do, Mark, is go live, and then you will see it on my page, share it from your page, and then we'll officially start. How does that sound?
Yeah, should we have our screens off first and then turn it back on?
Sure.
Just so we, aren't staring at the screen strangely. Um,
If you want, I just noticed, by the way, your head is on the bottom half of your screen. Um, if you care about that sort of thing. There, that's a little more. I can see your carotid artery a little better, or whatever. All right. Um, all right. I'll say go live. Going live, my friends. You just let me know, Mark, when it seems apparent that I'm going.
we're good.
We're good. All right, everybody. Let's turn cameras on and feast the world upon this lovely discussion. My friends, welcome. If you're just stumbling upon this, or if you've come here intentionally, this is Michael Hamm and Dr. Mark Olson, um, here to have a little discussion, which we hope will have happen in future times as well, where we're going to talk about the ecology of the nervous system as it interfaces with specific tissues as well as with lived experience. And this is an area of shared interest between Dr. Olson and myself. We thought we'd talk about ecology uh, because of the recent Earth Day, as well as it's a capacious topic that helps us get to practical implications as well as theoretical nerd stuff, both of which are of interest to me. So, my friends, my name is Michael Hamm. I'm an instructor for professional body workers as well as mind-body practitioners more broadly, and I teach anatomy physiology in a number of institutions, including one run for many years by Dr. Mark Olson. And I was so grateful to be asked to have this discussion with you, Mark. It's a little bit about me. Would love to hear a little about yourself and what brings you to this world of embodied ecology.
Yeah, thanks, Mike. I'm so glad that we're doing this. My name is Mark Olson, as you just said, and I've really enjoyed working with you over the years, and I just thought it'd be really great if we could formalize our interactions and share it with the world a little more, because I think we have a lot of fun things to explore, and uh, yeah, I just think that this is going to be a lot of fun. At least it'll be a lot of fun for me. I hope it's fun for everybody else too.
Yeah, I think if we're having fun, the fun has a certain virality, infectious nature to it. So I'll hope to pass it on a little bit. Mark, I want to start with just a note of admiration. I really see you on a tear in recent weeks, in a good way. I see you trying to create concise synopses of what I think for you is a vibrant new way of thinking about body work, about helping folks come back to themselves, and one that is both rooted in a a sort of kind, affective approach to the whole being, as well as in rigorous scientific inquiry. And so that's a hard weave to do. And I think you're one of the folks doing that hard work really elegantly, and making a lot of connections in the process. So well done on that. A little, in a bit, I'll be I know one of the things you've done is create like a flow chart of ascending levels of organization of the nervous system to try to understand how we experience our embodied self and how then that self can become dysregulated, re-regulated. So at some point, we'd love to look at that chart
Yeah.
with you. Um, but maybe to start, I'm so curious what when I say ecology, you know, that means something to me. It means a way of thinking about the complexity of the human being, the human body, uh, and yet not being drowned in that complexity, right? Ecology is in the wider world a way of working with the natural world in an ordered way, even though you can't predict all of its behaviors, right? Even though you cannot understand everything about the natural world. You walk into a forest, you know for sure you'll never learn everything about it. And yet, could you help it come into better balance? That's the question of ecology. And I think it's the question we can ask about a single individual in our care as well. So what does that mean to you, and what does that make you think of ecology?
Yeah, I think you said it really well. I don't know if I could describe it even more poetically, that's for sure. I think we want to talk a little bit about the ecology of the nervous system, right? The nerves and such. And I just think that's such a beautiful way to think about it because we just tend to not really like the nerves are just sort of an afterthought so often in these discussions. Not in discussions with you, but in the manual therapy field, it just tends to be like, oh, they're sending signals this way, they're sending signals that way, but we're not really thinking about how those conduits are doing and whether they're an important part of the whole picture. So I think it's really, really interesting to think about, how much of what we attribute to other
Discussions
parts
with
of the
you, but
system
in the manual therapy.
are actually due to, the lack of ecological health of the nerve. So I want to dive into that with you, unless you have another angle you want to start with.
Interesting. So so there's a I mean, of course, I have my biases that I'm really interested in, like the local ecology of a nerve in particular, as one of those interfaces where somebody's persistent dysfunction perhaps can live and can be effectively treated. Um, uh, I think yeah. Let me see if I can find a good image here, my recent whiteboard image. While I'm doing that, let me just communicate my own biases and I think the blind spots that might arise there. I'm unapologetically a nerve guy, and the reason is partially because it gives me a way of bridging my initial training as a body worker, which was really rooted in the physical construction of the body. Um, and I think what has come more and more into the explanation of like what causes the change we observe in a session, right? What is our theory of change? And as you know, I am not sort of a pure nervous system change person, but I think that there is uh, that it is anybody who's paying attention to the evidence about what changes during a bodywork session or a movement therapy session, um, uh, I think has to start de-emphasizing how much change there is in the hard connective tissues of the body and start recentering that change as a series of layered re-regulations. Um, re-regulations of local inflammatory behavior, re-regulations of segmental reflexive protective mechanisms, re-regulations of coordinative homeostatic orientational processes in the brainstem, and so on into our layers that that get closer and closer to our particular human nervous systems. Um, and I think one of the first places where I understand inflammation and homeostasis come into play is at the level of a nerve as it relates to its local tissue. So um, stop me when you get bored here, but here's a recent whiteboard,
Beautiful.
and uh, it takes me an embarrassing long time to make these whiteboard drawings, but essentially, this is a recent case where a person has come to me after an ulnar repair surgery. So this was a fractured ulna from a fall. And initially, there was no issue with nerve. However, the physical therapy was quite, shall we say, tissue based. It was all about getting getting a return of elbow flexion at whatever cost, right? So it was a very aggressive, okay, you've had a fracture and a surgery, lots of inflammation around the elbow. Classic pattern of local joint inflammation at the elbow is limited flexion, right? So my patient was instructed by the PT to really push that and get more degrees of flexion, which is an important parameter. Um, and there's a certain school, I think, of rehabilitation that says get the tissue there and the organism will follow, right? Just find a way to get the tissue there. You see this in total knee replacements and ACL reconstructions as well. Just like really orthopedic rehab, just push the tissue there. And my patient dutifully did that and caused a large secondary injury to her ulnar nerve. And the so what she was left with, and this is a musician, was left with kind of an inoperable pinky and ring finger, some weakness in the thumb, as well as a lot of paresthesia in the ulnar distribution. So a really unfortunate secondary injury, I think, due to bending the elbow in the presence of inflammation. And she's beginning to heal, but it's been, 10 weeks, 8 weeks of slowly recovering from a nerve injury, and an unnecessary amount of pain, suffering, and uncertainty as to her future function. Um, so that's the case, and it's a case where it really mattered, I think, for me to have a model in my brain what a healthy nerve looks like. So that's what's above here, versus a nerve that is in various forms of disruption or in fact, uh, actual breakage of elements. And so a healthy nerve to me, this is what an ecology looks like when it's balanced. It's got a healthy nerve has mobility within its sheath. We call it mesoneurium. It has lots of ample blood supply. The nested layers of dense fascia, dense collagen here, which really are an extension of the meninges at midline, are able to maneuver themselves in relation to each other. These fascicles, especially when a nerve crosses a joint, like at the elbow, you notice that the ulnar nerve has lots of fascicles, and those fascicles can rearrange themselves within the larger sheath. Um, and that's important because passive redistribution of force ensures the availability of blood supply. Um, and then getting down to a level of the sheathing of the individual conductive fibers, this is small, but not unimaginably so. So an average human hair is about 80 microns thick. And we're talking about, between a quarter of that or a tenth of that. That's about the diameter of an axon. Uh, and and so we have the Schwann cells, the myelin sheath wrapping the fast conducting axons, or in the case of so-called unmyelinated axons, we have a Remac bundle. That is to say, a bunch of little axons nestling in the warm, soft bed of a larger Schwann cell. Um, so why?
Sounds cozy.
I'm sorry, what did you say?
Sounds very cozy.
Yeah. Now I know this is all fairly known to you, Mark. The significance of this to me is all of this vast architecture has evolved to accomplish this very unlikely thing, which is that, you got a cell body living in the anterior horn of the spinal cord or the dorsal root ganglion, and it sends this wispy little cytoplasmic projection that we call an axon. This part of a cell, so so far from its original cell body, and along the way, it has uh, this procession of helper cells, of Schwann cells, um, that keep it fed, keep it nourished, keep it regenerating after injury. Um, but in order for that whole system to work, it needs to be ensheathed with ample blood supply, lots of oxygen and glucose, and removal of waste products. And it has to have this intricate system of mechanical dispersion of forces to function well. So uh, that's the state of affairs when it's healthy. And importantly, it's all about maintaining this blood-nerve barrier so that things can pass through that last layer of endoneurium and and the interior can have access to all those resources. When things get disrupted, the first and most common thing that happens, and you can, generate this if you even just rub on your own ulnar nerve, you find you find your elbow, find the olecranon and the medial epicondyle, and somewhere between them is an ulnar nerve that if you rub on it, you'll probably feel two things. You'll feel a little zing in your pinky and ring finger. You'll also probably feel some achiness here. That achiness is neuroinflammation. It's a gentle activation of the intrinsic nerve supply of the nerve, causes blood vessels to dilate, causes things to become sensitized in the sheath of the nerve, but also in sometimes in the surrounding tissues. So a lot of aches and pains that we might have uh, surmised as caused by, you know, a sort of local tissue mechanism, like, oh, your foot isn't properly aligned, uh, or your rotator cuff isn't strong enough. Maybe a lot of ailments that we experience as aching pain have this neuroinflammatory component, which changes a little bit the focus of any therapeutic approach and also changes the cautions you might employ. The sort of where are the drivers and what should you uh, focus on, what should you avoid doing?
And with that neuroinflammation, is there, are we imagining that there is, you mentioned ample blood flow. So are we imagining that it reduces that blood flow or it makes it unample, if that's a word?
Uh, Quite the opposite in the early stages. That's to say, neuroinflammation, I see, and I in fact think of inflammation more broadly, not primarily as pathology, but as a homeostatic mechanism in tissues to change priorities, right? And so, if you were to expose an inflamed nerve in a animal model, or in a human, if you were being feeling ambitious, you'd see that the surface of the nerve, which looked kind of pearly white, perhaps with a few blood vessels, the surface of the nerve ends up looking bloodshot, like a bloodshot eyeball.
Mm.
And I think a lot of neuroinflammation is an attempt by the nerve to get more blood, to get more resources, and those resources are important if what you need is either more oxygen and glucose, so neuroinflammation can come from metabolic stress, or if you need to repair something. If you've got a bit of a nerve injury, you need some immune cells to travel to the site of the nerve and repair it. Um, However, you talked about circulatory stricture. I think something that can happen at nerves, especially in tight tunnels, is that the nerve gets swollen, uh, and then that swelling impedes the blood flow, and other circulatory flow around the nerve, causing a kind of breakdown of the conveyance of stuff. So, in fact, just yesterday I had a patient with some medial knee pain that I'm pretty sure, initially had a hip flexor injury and then a whole bunch of aching pain through the quad, that seemed to be due to a branch of the femoral nerve getting inflamed. And then about a week later, started getting a patch of numbness. here in the medial shin. So my theory, we'll see if it's true, is that there was some neuroinflammation initially from a local injury, and then uh, the a branch of the femoral nerve passing through a tunnel at the knee, saphenous nerve, uh, had this secondary swelling and stricture causing some numbness more distally. And so inflammation, like so many other protective mechanisms, I think of as kind of an overenthusiastic friend. Um, that's sort of, successful enough to pass our genes along, but doesn't make us comfortable always. So,
Yeah.
um,
It's interesting to me that it takes time for that to occur. Like there's this the theorized lack of blood flow, and it has a slow. I mean, if I sit funny, uh, uh, at times, my whole leg will go to sleep, right? It's like it's going to sleep because I've cut off the blood flow to the nerves in my legs, right? So, um, I don't. I mean, I guess it's painful in a sense, but it's not the same kind of problems, that happens in a few minutes. And then your client, you said it took like a week. So, um, I just think it's really interesting that the body is still, kicking along, but not having enough. Like, because there's this, for me, there's an idea that, well, if we don't have enough, the cells are just going to die. Uh, so it's interesting to me that there's a range where the cells are like, I can keep doing this, but I'm gonna not function as well.
yeah,
Was that what your understanding is?
I think you have zeroed in on something really interesting, which is like on what time scale does the peripheral nervous system experience dysfunction, right? And what's to account for those different time scales? Like I can sit on a butt. I can sit on my butt rather. I can sit on. I can take a nerve into a stretch position for a minute or two, and I begin to experience neuropathy, right? I begin to experience obvious changes in the ability to pass signal along that nerve. That I think is a different phenomenon than the dying off of axons. I think of that as like a, a closure of resources, a ligation of blood supply, causing sort of conduction to break down, right? So um, the first thing that happens, you sleep in a funny position and you wake up with a numb arm. Uh, that everything here might still be alive and intact. However, the ability to transport ions to across the surface of that axon to maintain a resting potential, and then to convey signal that could be temporarily out of order if you don't have enough blood flow and resources. And we know this from animal models that if you take a nerve under normal physiologic conditions and you begin to stretch it, it doesn't take long. You take it to about 50% stretch, and a majority of its blood supply has already been ligated. You take it to 80% stretch, and blood cannot penetrate into the nerve anymore. Take it for what it's worth as an animal model. But the thing is that mechanical stress, the first thing it does is it prevents nerves from having a really rich interface with the circulatory system. Um, Now, oftentimes you wake up in a funny position. It's not just that you have a numb arm, but maybe you have a crick in your neck. And one mechanism that could explain that is that the nerve has a secondary strategy for getting more blood. Um, if it can't get blood from normal mechanical redistribution of pressure and tension, it begins to secrete inflammatory cytokines. The lack of oxygen and glucose says, "Hey, I need more. So let me begin to dump some substance P and some CGRP into my local tissue. That'll cause the blood vessels to dilate. Whoopee, I have preserved myself by getting a bunch of new blood. And and indeed, if you sit on the edge of the toilet seat for too long, uh, not only will your feet be numb, but the back of your legs might get achy. So
Yeah.
I think it's possible. I think this explains a fair bit of the transient neuropathy we feel. Bad position, lose lose blood supply. The nervous system doesn't like that. Will often cause you to move in your sleep or shift. Um, or you'll be like, "Oh, that's a funny sensation. Let me get off my cell phone and finish on the toilet, and etc." Right? But the second mechanism, the one where there's this dying off of axons or this kind of persistent dysfunction. I think that's when the metabolic stress exists for long enough, or when there's a severe enough injury that you really have a rupture of some internal elements of the nerve. And then
Just
the whole question of how recovery happens then.
so something about the long enough piece is changing the ecology. So rather than these temporal moments, sitting on the toilet or whatever, yeah, a person has low back pain or they experience, chronic pain between their shoulder blades. Uh, Maybe we're talking about an unhappy ecology here, but it's emerging maybe differently because it's taking a while, and so you know substance P, other things are being secreted. I mean, why don't people just go numb? Why would you say why do we end up with pain in those situations rather than just people complaining about them feeling numb in those places? Got any thoughts on that?
You mean like if there's been a persistent irritation or
Yeah, maybe like you gardened all day and you hadn't done that in a while, and the next day you wake up and now it's kind of hard to walk or it's hard to get out off the couch or um, you just have these, I mean, we're not talking about an overuse muscle thing. It's just that's a different, I think that's a different thing. Um, Something about it has a clear nerve quality to it, I would say. Um, for some people. They say, "Oh, yeah, my back, it's doing that thing again." That's different than I went out and ran a couple miles and I hadn't done that in a few years. That's a different feeling. I think.
yes.
Do you know what I'm talking about?
Yeah, so I think here's one of those places where it becomes really interesting to think about what layer of the ecology is being altered to produce that kind of not only a transient disruption of symptoms, but a tendency, a different tendency, right? Um, so to use a term from ecology, it's like what is the homeostatic norm back to which you return, right? So like if somebody's basically healthy and they get out of position, they have some numbness or some transient discomfort. We've all experienced so many times we barely note it, a discomfort or a dysfunction in a nerve that uh, that we correct with enough time that things go back to normal. We've gone back to baseline. Um, and yet we experience all the time these situations where it's not only the momentary discomfort, but it's a tendency toward dysfunction and discomfort that characterizes our problem. There are there are some, to my knowledge, explanations for that at that tissue nerve level. So if I one shared with me by Dr. Jeffrey Bove, who studied this a lot, is that suppose you have a nerve that has gotten inflamed numerous times, and so it's gotten very inflamed. Well, this is a sign, that evolution is not a designer but a tinkerer. Immune cells migrate to the nerve, and the blood-nerve barrier becomes more porous. This happens because of TRPV1 receptors and other things. There's more of a porous relationship between the blood vessels and the conducting fibers. And what happens is that immune cells migrate from the local capillaries into the endoneurial environment. and they do their repair work there. They come in, they amplify the inflammation, and they might eat up some detritus. And in a purely ideal situation, those immune cells then either die off or they leave. But what we see in nerve histology, where there's been repeated instances of at least experimental neuroinflammation, so literally putting hot sauce on a nerve and seeing what happens, is that immune cells like macrophages and neutrophils can get trapped in the endoneurium, in the perineurium, in the epineurium, and you can have an incomplete conclusion of the wound healing process here, or the inflammatory process. And they become trapped, but they don't necessarily die off. And so for at least an extended period of time, probably not a lifetime, but maybe weeks, maybe months, you've got a bit more tendency toward irritation, toward amplification of immune response because of some local resident immune cells trapped in a formerly porous blood nerve barrier.
Hmm. So it's kind of a adding pressure kind of idea. Like that
It's
there's more things inside.
I'm not sure if I don't think of that as a mechanical hypothesis. And to be clear, this is totally a hypothesis based on some observations of histology. Um, I think the idea is uh, what happens in inflammation, right, is that you've got some initiator cells that, numerous things can spit out cytokines, and then fibroblasts and immune cells begin to cascade upward and amplify that inflammatory response so that it becomes influential on the whole organism. And if you've got more immune cells trapped locally, they increase the upward curve of that cascade. It's like cranking the gain on a volume knob. And so
Okay.
you've got a more enthusiastic inflammatory response because of those resident immune cells kicking up a fuss. So that's the peripheral, or at least the nerve interface idea. I think that's a hypothesis. The most convincing one for me, and is that uh, things can change at the dorsal root ganglion. Um, so that if you've got repeated inflammatory stress, the cell body begins to manufacture different receptor proteins, begins to exist in a state of predisposition toward inflammation, um, uh, that perhaps it didn't have initially. And so, for my money, the way that persistent tendency toward inflammation can happen is that, like, you've got a systemic stress state. You're not just in the garden, but you're worried about your mortgage, and and then
Mhm.
you've got, then you tweak your back while shoveling, but something about that behavioral context means that you don't just have a healthy, warm, happy inflammatory response. It's a response where you've also got central signaling indicating a state of threat or danger, and that says to the dorsal ganglion, "Oh wow, I need to get better at detecting damage. So let me manufacture some more, you know, sort of some more receptor proteins. Let me try to shift the whole tendency of this nerve toward detecting threat better." And then onward up the central nervous system, you can have synaptic change at the spinal cord, and that's, I think, the big question for me is on what level is the organism changing? And I think the longer it's been around, that tendency toward irritation, the more likely it is to have uh, enacted changes in the central processing of that pain and that inflammation.
Mhm. And that's interesting to offer a immune endocrine explanation for what's going on because people tend to have the same thing, oh, that one spot in my back, it once again always flares up kind of thing. And I think there's a tendency, obviously there's this very tissue oriented perspective that thinks that there's something wrong with the muscle or but I would even think, oh, well, there must be some place where that nerve is becoming irritated on its way to that place. And with, the nervi nervorum uh, being activated around the nerve. So, how would we distinguish between that immune explanation that you just gave and one of, oh, that nerve is having trouble passing through some fascial layers on the way to its peripheral location. Like what would be the difference? I mean, I would imagine that they end up playing off of each other, but those are different explanations, though.
Yes. Yeah, I don't know if anyone's done the work of trying to take that little like trapped immune cell theory and connect it to any kind of therapeutic testing or history taking or something like that. I'm not in the daily practice of taking biopsies of nerves from patients of mine. Um,
Yeah.
the you know the thing that I am often interested in is this is still pretty accurate for me. It's an old slide. I'm often interested in like, okay, can I think flexibly about like if someone's got an issue, is it happening at the sort of tissue interface, the end plate of a nerve, the receptors in the tissues? Is there something dysregulated happening distally along the end of the nerve? Is there, as you say, some stress on the nerve within its sheath while on its path to that local tissue? And then are there sort of representations of those tissues on ascending levels of the nervous system that are somehow dysregulated or fraught or coupled with protective behavior? Um, to me, the
To be
easiest,
clear, just to be clear, the immune explanation that you gave, where would you put that in these three?
I actually think it could happen anywhere from anywhere along the peripheral nerve,
Okay,
including,
okay.
uh, so anywhere where you have inflammatory stress on a nerve, I think that could apply. So I'm not sure if it's distinct from what you said about like entrapment of a nerve along its path. I can say
Mhm.
on the macro level, one of the ways that I try to integrate this with daily practice, having a lot of humility, is just to try my best to palpate along the length of a nerve. Um, so we have, in the world of neurodynamics and, Shacklock and Butler and all of the brilliant Australians, we have ways of positioning at least for the long nerves of the body, positioning the limbs to take slack out of the nerves and then selectively try to stress them at particular interfaces to get a sense for where is the driver. I think that can work really well for long nerves, but equally helpful in daily practice for me is to try to just do my best to put pressure with my fingertips where I think the nerve is from the midline out to the tissue and see if I can reproduce symptoms. See if I notice obvious signs of swelling or heat or exquisite pain. Do I know then if I find such a site, do I know it's the primary driver of somebody's symptoms or dysfunction? I don't know that yet, but I know I probably shouldn't ignore it, right? I know it's probably part of the story. Um, So more testing would be needed to see like how important is it. But like if I've got somebody with low back pain, somebody can have pain in their hips, for example, and uh, and they'll talk about pain. Sort of here's the greater trochanter, here's the iliac crest, and they'll talk about posterior hip pain. Now, if I palpate along the iliac crest, so a bony ridge, pretty obvious, and if I just put pressure along this and somebody gets familiar pain, reproduced further down as I go along there, and then I also notice there's some swelling there, that's a different implication than if that person's hip pain, if I did that palpation and there was no reproduction of pain at all, right? Um, One suggests to me that the hip pain is is probably being contributed to from nerves flowing from above, cluneal nerves flowing over the iliac crest.
Mhm.
Um, Another suggests another mechanism, a deeper one, or and again, I'm a very this is the way in which I'm tissue based, is that I believe in my ability to poke at things and learn things about what I poke. Um, uh, yeah, but it's a good question as to like uh, what's the meaning of that immune hypothesis? I think for me, it to know that there's this interface between a peripheral nerve and the immune system gives me an angle into understanding why some people's bodies seem so tilted toward inflammation over time. So it's not necessarily that I can detect with a special test a site of in migration of macrophages onto a nerve, but I can say, like why is this person with autoimmune disorders or this person with mast cell activation syndrome uh, or this person with connective tissue disorder, what's one way that I can try to understand a systemic tendency toward amplified inflammation? Um, and that can then inform a whole bunch of things about how I stress their system in practice. How much when I'm doing a nerve tension test, for example, like how much mechanical tension do I put on that system, or what kind of massage am I hoping to do? I have a number of patients who are just tricky because I'll do the best version of neck work that I think I can do. And then they're like, Mike, that was such a great session, but I am always in pain for a day or two afterward. And I'm like, oh man, that wasn't my intention, right? Um,
Yeah, and but presumably because the immune system wasn't having it, right? That's what you're suggesting there.
yes, and in particular, these situations can arise. I What's confusing for me as a body worker is that I feel pretty well trained in reading the autonomic nervous system of a person in my care, reading the emotional landscape. So I feel like if somebody is coming in with like overt big protective behaviors, they either say ow a lot or they engage in like muscular protective behavior. Um, I I will notice that. I will change my approach if I notice that the emotional or autonomic nervous system doesn't trust what's happening. I will
Mm.
change. But there is a subset of persons where they're calm. They like me. They trust the environment. They're not registering pain in the moment of contact. Um, and their muscles aren't fighting me, right? It feels like a congenial conversation with their tissues, their nerves, their brain. And yet, uh, a normal experience that they have after body work is just achy, boggy pain in the areas worked, and not just body work, but going dancing or going to a yoga class, like any tissue that gets certain stress, or lifting weights, they pay a higher price in the hours and days after stressing a tissue. And it doesn't seem to be centered in at least a systemic perception of threat. It's like whatever's happening in that normal, natural inflammatory response. You lift some weights, you get a natural inflammatory response afterward, but somehow the cascade is higher for them. And that's the sort of person where I think about immune stress as playing a larger role.
Yeah, absolutely. Which would then also be enhanced by other aspects of their life because of the descending qualities from the central nervous system, right? Would you imagine that would be the case?
I think so. I think it can definitely create patterns of learned patterns, operant conditioning patterns of where somebody will try to challenge their system, and they will learn over time that going to get body work or going to the gym necessitates pain, or it necessitates the emotional fortitude to, or perhaps it's almost like a learned helplessness, a rat that gets a shock unpredictably and stops caring whether or not it gets a shock. Um, so the randomness sometimes of that inflammatory response can teach a person implicitly a lot about, like, the inevitability of pain, which is unfortunate. But perhaps it's rational for them to behave, to respond that way.
Yeah, if
You
it's random, I mean, that would be rational. And then it seems like if we could help them find out if there is anything that's not random, that would be useful. Because
That's true.
if it feels random, then what are you going to do?
Yeah.
You start to notice that there's these certain patterns, then that gives you some agency with it.
Yeah, I had, sometimes the insight comes not from the care itself, but in care with someone, you can help someone really develop a sense of what is the unanswered question here. So, like, I've had persons in my care who I have a really strong relationship with, and we keep working on the same problem, and we're honest with each other about the non-success we're having.
Mm.
And yet, and I think that my first tendency as a body worker in my early years was to, if somebody says, yeah, that didn't help, actually, I still feel in pain, my first response is like, sorry. you know um but if I can stay in relationship with them and say, I say, that's really interesting, because I really thought we did some things to help, and yet it doesn't sound like it helped much. And she would say, I'm calmer, I really enjoyed our time, I'm not in any less pain. And this was here's a situation where, for years, I was treating someone with always had right-sided neck pain, uh of this diffuse, achy, boggy quality, and very rich therapeutic relationship, lots of other things we worked on successfully. So body work was helpful for this person. However, this right-sided discomfort didn't seem to go away for several years. It would come up, come down. We'd work on it. It would flare. The biggest difference that happened was, then she one day she went in to the dentist, and they found that her rear molar had an infection in it. And upon treating that rear molar with a root canal, um, this right-sided neck pain that had been with her for years reduced significantly. Um, so as happens in the history of science, and also in sort of therapeutic relationships, sometimes you can help a person just rule things out, right? And develop a real clear sense of what's not changing, so that then they can come to another healthcare provider and be like, all this other stuff, this is a movable feast, but this one thing remains. What is that?
And it's interesting that she wasn't experiencing pain in her jaw.
Yes.
You that's yeah, that's really interesting. What do you imagine? Do you imagine that that inflammatory response was spreading through some of the cervical nerves, or do you imagine that it's the representation in the central nervous system, like brainstem or somatosensory cortex?
It's a really good question. I Ask me on a given day, and I could give you a different answer, especially when it comes to, like, inflammatory behavior in nerves in the cranium. There's a lot of crossover, that I could imagine as literally sort of an inflammatory process that spreads over dural tissues here, and or a sort of referral pattern, right? So, um, as an aside, I've heard from many dentists that people can have tooth infections and not be aware of them. And
Hmm.
uh, surprise, the world of dentistry doesn't have a great explanation for pain, for the different versions of pain. Um,
Yeah.
uh, so, uh, number one, the referral idea. Uh, we know that trigeminal nerves converge on a part of the brainstem called the trigeminal cervical nucleus, and it's a sensory nucleus that receives sensory input both from the trigeminal nerves in particular, but also the upper half of the neck nerves, right? So any of the nerve roots C1 through C4 um, also converge on that same nucleus, which is why a lot of headaches can be generated by irritation to the upper neck, right? So cervicogenic headache is best explained, I think, by that convergence in the brainstem. Um,
Hmm.
and a good way to tell is if you find an irritated segment of the neck and you push on it, does it reproduce your headache? It's a good sense of that. Okay, that's a cervicogenic headache. Um, is there
Which
toothogenic?
wouldn't be, which
Right,
wouldn't be an immune thing. If you press on it and then you feel it, then there's this nerve signal
right. That
rather than inflammatory response. Yeah.
that would be the wiring diagram, right? That would be a referred pain phenomenon, a mismapping of where the problem is by the brain. Um, and so I think it's reasonable to say it was somewhat reasonable to say, okay, tooth pain converges there, and the brain interprets it as being neck pain, right? So toothogenic neck pain. I think that's a really interesting hypothesis. The distribution was a little bit mysterious because it felt like broader than just the kind of trigeminally overlap
Mhm.
stuff, but it's also a good reminder that real humans diverge from the anatomical models, right? Sometimes, an,
Yeah.
there's been anatomical studies of like a dorsal ramus nerve coming from the mid thorax back here, between the shoulder blades, and then it comes to the skin here, coming out from maybe the third or fourth thoracic segment. But then they follow this one nerve all the way over the iliac crest down in it's a cluneal nerve, but it started in the mid thorax, and
Ah,
uh, and that's just how that cookie crumbled in the embryogenesis, So, um,
yeah.
people are weird,
Freaks
and
of nature.
well, you look close enough, and there's a freak in all of us, I suppose. So
Hmm.
Mark, we've had a great discussion. We have probably a few minutes left. I wonder if any of this can bridge into some of the work you're doing. Um, and I'm really open to you talking about like how the work you're doing with kind of interoceptive models of self-regulation, or if that sort of hierarchy diagram of the brain feels helpful to bring in.
Well, maybe with the time we have, it might be a little challenging, but I think this was very informative when I think about the model that I have been trying to put together from bits and pieces here and there of how this all works. And, uh, I often talk about the tissue model, which is really more of like a mesoderm model where there's this focus on muscles and fascia as being the issue to focus on. But we're here at this interesting interface. We're looking at immune function in the nerve, which is different also than this, understanding pain from like central nervous system processes, right? So there's just all these levels that engage with one another, and um, I'm glad that we can dive into this complexity and uh, I think I really liked your diagram of the one, two, three, the one at the tissue nerve interface and the one along the nerve, and then anywhere else along the the pathway. Yeah, that one. Thank you. Um, And I think it's useful to, go further into three there and, talk about what's happening at the spinal cord and what's happening at the thalamus and what's happening in the limbic system and how that interfaces with people's thoughts and the experiences they've had. So, and we touched on that a little bit. So, uh,
And just a note in favor of that third column, that central nervous system. This is quoting Diane Jacobs, dermoneuromodulating. Take it for what it's worth, but Diane would say, just look at the number of neurons, the number of synapses, from tissue to to anterior horn or dorsal root ganglion. That's one axon, right? Uh, and then you've got a synapse in the segmental level of the spinal cord. You've got some local interneurons there at that level. You've got maybe some central pattern generators in the spinal cord. But like the vast majority of synaptic connections and neurons are in this dark continent of central nervous system, and it's it's we know more in a way about the periphery, right? We have it more mapped out, and so at least those of us in physical medicine know more about that, and so it's more apparent to us. It's easier for us perhaps to imagine a peripheral mechanism, but if we simply take on like if we were to put nerves and neurons at the center of our picture to say where are the most neurons, the most opportunities for changing the gain knob on pain or on protective behavior, there's more opportunities centrally, right? There's more
Hello.
influence. So
Mhm.
that would speak in support of venturing deeper into that central system.
Yeah. And even so, I would say I remain agnostic about what percent of chronic pain is like where that is coming from. I think this immune piece that we touched on today is probably a huge piece, and the endocrine piece is a huge piece, and uh, I would have no guess. I wouldn't want to have some troll say I can't cross the bridge until I can answer that question adequately enough. Give me a few more years, maybe, but not right now. There's too many mysteries, which I think, well, that's why we're here, right? To explore the mysteries and maybe explore more of that next time.
I think that sounds fun, Mark. I really had no idea where we were going to go today with all of
Mhm.
this, and until about 5 minutes before our live stream, I was just trying to calm my gigantic dog down. So I was in a different headspace. Um, but I will share that I am, a large part of my life right now, to the tune of 19 people a week is being right up against my own incompetence with trying to figure out what is the assume that everyone who comes in for a therapeutic session of whatever nature of their challenge, assume they're trying as hard as they can, right? And assume that they are more or less able to understand the available information out there about what could be, causing their issue. Uh, where is the place in their system that if we focused our attention would cause the most good, right? That's a definition perhaps of a driver, not what are the many, many causes? Because of course, like what's the cause of your pain, Mark? Well, it began with the Big Bang and the formation of basic matter, But like, what's the cause of your recovery? That's the ecological question for me, is what part of this incalculable complexity is most likely to help the whole, right?
Yeah.
Um, and the only way that we can actually find those kinds of drivers is not by having the perfect theory a priori, on paper, but it's about having the available options, keep turning the soil of the best hypotheses we have, and then meeting with a real human and sifting those possibilities, auditioning them with that system, and trusting that the interaction generates and refines, a sense of where the most beneficial change can happen.
Sounds like curiosity would be important.
Yes. Yeah, I was once in the back.
Humility.
I was once in the back office of a physiatrist, pain docs, and I was bringing them lunch in an attempt to get more patients from them, and it worked. But they were chatting about, one of the physicians came in and said, what did he say? He's like, "Well, I just saw another lumbar disc herniation," and the head doctor said, "Now wait a minute, Jim. What you saw was another person with lumbar disc herniation." Um, it's a natural way for those of us in sort of helping professions, medical professions, to categorize, to abstract, and to say, yep, another classic lateral ankle sprain. But when we do that, we can do that as a cognitive aid, but if we do it as a way of shutting down our curiosity, I think it gets boring, and it also um, it shuts down the ways in which this person is weird and unique and uniquely creative in finding their way to recovery. Yeah.
Mm, indeed. Indeed. Well, do we
Should we
should we
conclude?
call it here?
Yeah, let me just thank the folks who logged in and commented. These sorts of live streams are way more fun when there's a little bit of community hanging out. So Jen, thank you for the comments. Sarah, yes, grateful for your presence. Caitlin, I am I am so inspired by your ability to find and comment on stuff that we're doing. And Dr. Olson, whoever that guy is, stop stalking me on the internet. Um, uh, uh, Mark, I hope this is not the last time. I know we'll be meeting again. It's been a long collaboration, but it feels fun to do something a bit new with you.
Yeah. And should we tell everyone that we're intending on doing this next month as well?
Yeah. We'll do this next month, and we'll tell you about it on our respective Facebook pages and newsletters. My Facebook page, Nerve and Soma, and yours, uh,
Dr. Olson.
Dr. Olson. So check that out. We'll link that in the description of this live stream. And please continue to comment. Next time we'll take a little more time to look at those comments and maybe respond to a few in discussion. That would be fun.
Yeah, that sounds good.
Thanks, y'all. Good to see you,
All
Mark.
right. Good to see you.